Hi, I'm Jim Brett, President and CEO of the New England Council. Thanks for tuning in to this month's episode of Inside the Corner Office, where we catch up with the leaders of some of our region's most well-respected businesses and organizations to learn more about their career paths and about the institutions they lead. This month, our guest is Dr. Eric Dickson, the CEO of UMass Memorial Health, based in Worcester, Massachusetts. Dr. Dickson shared his unique career path from serving in the military to pursuing a career in emergency medicine, and ultimately to leading Massachusetts' third largest healthcare system. We talked about UMass Memorial's efforts to ensure equitable access to quality healthcare and the lasting impact of the COVID-19 pandemic on the healthcare sector. We also discussed how workforce shortages are impacting the healthcare system in our region, particularly in light of increased demands for mental and behavioral health care services. As always, I thank you for tuning in. I hope you enjoy the conversation. It's great to see you, and thanks for taking the time to join me today.
Well, thanks for having me, Jim. It's really a privilege to be here, and thanks for all the great work that you're doing with the New England Council.
Great. You know, one of the most interesting parts of hosting this podcast for me has been the opportunity to hear from so many impressive leaders about how they got to where they are today. And you have your own very unique story, to say the least. So let's start there. You did not originally set out to become a doctor, but rather join the military. Can you share more about how you came to pursue a career in medicine and your interesting career path that brought you to where you are today?
My dream coming out of high school was to be a helicopter pilot, and I joined the Army right out and started down that pathway. And it turns out I kept on growing after high school, and I didn't fit particularly well in a helicopter by the time I got to my flight physical. And because I had already joined the Army, they don't let you out just because you have to. They just tell you, well, you got to choose another job. And went through the options based on my testing, and they said, yeah, you'd be a great combat medic. And didn't really know anything about medicine at the time, and ultimately did train with the Army as a combat medic. Loved working with the infantry guys, where at the age of 19 years old, they were calling me Doc, and that's what you call the corpsman in your group. And I just kind of fell in love with it and taking care of people when they were hurt, and that got me started. Ultimately, the Army trained me as a respiratory therapist, and it was during that training that one of my real mentors in life, Dr. Dan Coleman, said to me, Dickson, you're too smart to be a respiratory therapist. I need you to go to medical school. And he was a colonel, I was a private, and so I took that as a direct order and started down the pathway towards going to medical school, did my pre-med at Merrimack College, and then took a job here at UMass Medical Center as a respiratory therapist, hoping to get into med school there. Did get into med school at UMass, just a fantastic, incredible asset for this state, the state's only public medical school. Residency training in emergency medicine, first physician job here in Worcester, and kind of been here ever since, and loving every minute of it.
What prompted you to make the transition into hospital management and administration? And obviously, do you miss working directly with the patients on that day-to-day basis?
I definitely miss working with patients on a day-to-day basis. I love working in the emergency department. I've been in medicine for the better part of 4 decades, taking care of patients at some level. I do fortunately still get the opportunity to see patients in different environments and help out, although I'm not doing the late night Saturday shifts in the trauma center anymore. I have had to adjust that practice. The shift came for me in really becoming a chairman of the Department of Emergency Medicine, and finding that I was a really good problem solver. And sometimes I could solve problems in leadership roles that helped a lot more people than just a single individual when I was taking care of patients. And it is the part that you have to attach yourself in administration and in these leadership roles that you can never lose sight of. It's about making things better for the people that are kind of, to use a military term, on the front lines. And if it's not about that, then you shouldn't be in a leadership role. If it's about somehow elevating your own status or feeling better about yourself or getting a bigger paycheck, I don't think those people make particularly good leaders. It's the people that can stay attached to the work of trying to make things better for me, for our patients and our frontline caregivers. And that's what gets me up every morning. That's what makes me excited to come to work, and thankful for the opportunity to serve as CEO.
I think you were quoted as saying that you take talent over capital.
Absolutely. And I once had one of my senior leaders say, I wish you loved us as much as you love the frontline people. And I said, well, don't hold your breath for that, because it's the people that are down there kind of working in these very challenging situations in healthcare. They're who I get up for every day. And yes, you try to got to take care of management as well. But because coming from the role as a respiratory therapist, or really even a medic in a military hospital, you never lose that sense of, this is where the real value is created. This is where the real work is done. And everybody that's in leadership beyond there has to serve those people that are serving the patients. And that's what it's all about for me.
You've been outspoken about your belief in leading by example and being in, again, the trenches with your staff. I understand that you personally were administering the vaccinations at the community COVID vaccine clinics early in the pandemic. Tell us a little more about your leadership style and your approach to leading a staff of thousands. I don't know if it's 16,500 or something.
Yeah, we're at 17,500 employees right now.
Okay.
And
wow.
I could still use about another 1,000. We still have a lot of vacancies.
Right.
I think when COVID hit and everyone was afraid, and everyone was being asked to do things like reuse their mask and to work in environments with this disease that we had no treatments for. I think you have to lead from the front in those situations. And as somebody that had a lot of knowledge about respiratory illnesses, given my training and in emergency medicine, it was kind of a disease where it was right in front of the areas that I know best. And so I worked every night in the COVID tent, every Sunday night in the COVID tent, because we had to have a separate area and to see patients. And then when we finally got vaccines that we could get out, and a good test where we could test people. I don't know, people forget that we didn't even have a good test for the disease early on. It would take weeks to get a COVID test back during the first wave. My wife and I, who was also an emergency physician, were right out there doing vaccines in the homes of elderly people, and swabbing noses. And it's like anybody in healthcare can learn how to do a COVID test. And people see their leaders doing what they're being asked to do, and it calms everything down. And there were a few hospitals in New York where the presidents of the hospitals were in Florida during the worst parts of that. And frankly, it's the worst look possible. I mean, leaders should be seen in the setting where they're asking their people to go. And thankfully, I'm clinically trained and was able to help out.
I read somewhere that Massachusetts was like the third hardest hit state that was impacted by COVID.
Yeah, third or fourth, right in that area. There was 2 waves of COVID. People remember one came from Asia and hit California. That was a less potent form of the virus. And then the other came from Spain over into New England and hit New York and Massachusetts and Connecticut were hit really hard in that first wave. Ultimately, that became the predominant virus that swept through the rest of the country. But we didn't have the time to prepare because being hit first. And I think New York really had it the worst and had the most lives lost. And it's almost hard to imagine now not having fresh masks for people to go in. But that's what we were dealing with at the time. And in many ways, those of us that went through it together, I think we emerged stronger as a leadership team. and just more committed to making sure we did everything we can and do everything we can to take care of our caregivers. And as long as we do that right, the caregivers will take care of the patients.
Let's switch gears and talk more about the incredible organization that you lead. Most of those tuning in today are probably familiar with UMass Memorial Medical Center, but UMass Memorial Health is much, much more than just the flagship hospital in Worcester. It is, in fact, the state's third largest health system. Can you give our audience an overview of all that is included in that UMass Memorial Health?
Sure. Well, Jim, we were created by an act of the legislature. You probably voted on this at some point that to do three things: to take care of the indigent populations of Central Massachusetts, to support the state's only public medical school, and to provide services to Central Massachusetts that weren't otherwise available. And the enabling legislation allowed for UMass Medical Center, a state entity, to merge with Memorial Hospital, a private entity, and to move some state assets into the private sector. And that merger and that combination of that academic medicine and the terrific people at the medical school and the strength of the medical school, coupled with the kind of community work that Memorial had always been doing, has allowed us to just grow and grow over time. And I think what the legislature did with the creation of UMass Memorial is it created a better mousetrap, and slowly, essentially, every small community hospital in the region, except for a few, have come in to be part of the family and have been strengthened by that. Our most recent acquisition was Harrington Healthcare in Southbridge, and the campus in Webster as well. And they had struggled and lost money for 5 years trying to go it on their own. And they had came into the system, and within a couple of years, we were able to get them a world-class IT system and back to financial solvency by the power of scale and really the power of working with the great medical school that we have as our partner. And so, there was a time when there was 18 separate independent and public hospitals in Central Massachusetts. It's really down to UMass Memorial has 13 of them, 3 of them are out of business. Stewart has 1 of them, which is something we're watching very closely. And then 2 sadly bankrupt hospitals in Athol and Gardner that, hopefully we'll find a way to save working with the state and bring them into the system. But it's really, you have to have scale to be able to do what's necessary in IT. And the legislature created that scale by partnering UMass Medical Center and Memorial together. And that has really strengthened healthcare for the entire region of Central Massachusetts.
UMass Memorial is a unique system, and one that wears many hats for the communities that you serve. It is the Central Mass region's premier specialty hospital, and is also the region's only safety net hospital. Can you talk about what that means and how the system meets those different needs?
Well, for us at UMass Memorial, it's written into our enabling legislation, but really at the core of our mission is caring for populations that are underserved, caring for populations living in poverty, and making sure that we provide the services that they need. Services that the for-profits would run away from because of the relative profitability of providing them. Behavioral health services, addiction services, and even working on problems that wouldn't seem to be typical for a healthcare system, like food insecurity, and assuring that everyone has access to healthy food, which is the basis of good health. Right? And so what you find that we're doing a lot more in outside of the bricks and mortar of the hospital because we have one thing we learned from COVID is you have to meet people where they are, and populations that, especially for non-English speaking migrant populations, they're afraid to come to that big giant building on the lake in Worcester, right? And they don't have their support around them. They don't know the people there. And so increasingly to meet that needs and serve the community and serve those underserved populations, we have to go to them. We go to them with our care mobile that does dental care, primary care, urgent care, sometimes even go into the school systems and taking care of kids, with our Road to Caring, which is a mobile addiction treatment center, get right into the areas where people are suffering, and that team is saving lives every day. And I think medicine is evolving rapidly, in part because of technology, but also in part because we understand that you can't just expect everybody to come to the big building with the emergency sign on it. We have to figure out how to get to them and how to care for them where they are.
You know, so many people, they think of the pandemic as in the rearview mirror, but I know there's been a lasting and devastating impact in the healthcare industry nationwide. And here in New England, we've seen headlines in recent weeks about, the health system and financial crisis. Can you talk about the state of the healthcare industry here in our region and the lingering impacts of the pandemic on this sector?
Well, it's scary to say this, but the data, the actual facts, the numbers would say that it's never been harder to get a primary care appointment in the state of Massachusetts than it is today. The emergency department waits have never been higher. The emergency department boarding, patients sitting in the emergency department waiting for a bed, something we've been measuring for years, have never been worse. And you have 10 hospitals either bankrupt, Haywood and Gardner and Athol in bankruptcy proceedings, or 8 that are about to go bankrupt, the Steward hospitals. And so if you look back, and you've been around for a few years, Jim, when do you ever remember having 10 hospitals either in or on the brink of bankruptcy in the state of Massachusetts? We've seen 1 or 2 here and there. Yeah. And I've worked at some of them, Sims Hospital in Arlington, Sancta Maria in Cambridge. I've done some time in those places and watched them disappear, but we've never seen it as broadly challenged healthcare in Massachusetts as it is today. And I think with all great problems that we have, we just, like we did with COVID, we need to come together and kind of agree on a course of action and come up with plans. And what we have lost coming out of COVID is the sense of urgency, the sense that we have to work together, the sense that, we should be meeting on a regular basis, coming up and planning and empowered to make decisions. And we tried to go back to just, business as usual, and business will never be as like it used to be. There are going to be more patients over time because of the aging of the population, and less people to take care of them over time because of the change in the workforce, which is permanent. And so that means we need, novel, innovative solutions to taking care of patients. And that's what we've lost since like the COVID state of emergency. The flexibilities that were created, the ability to do a field hospital, the removal of the pre-authorizations, all of that we had with COVID, everybody said, okay, now we're back to normal. And frankly, we'll never be back to normal. So I think we've got to find a way to come together and kind of make decisions together and work together for all of the healthcare assets in the state so that we can get people the access they need to primary care and get people out of the emergency departments and keep them home and healthy where we want them to be.
Is it that your fellow colleagues feel like we're competitors against each other, and that's why we're not inclined to meet and try to solve the problems? I mean, what do you think is the impediment in getting them at the table?
I think this is a place where the government has to lead, and I think the state government has to lead. And Attorney General Healy during COVID pushed Governor Baker to regular meetings with all of the senior leaders of healthcare. And so what we would call the big 6 healthcare systems in the state, the CEOs of each would get together on a weekly call, sometimes bi-weekly call, and the now Governor Healy was on those calls. And we don't seem to do that. And we would tell the governor what we need. And so he had like a frontline understanding of what was going on. And we had a state of emergency, which gave him great flexibility in what he could do as well, and FEMA money and things like that. And I think we have to return to that a little bit. And where the heads of the big healthcare systems across the state need to get together, meet with the secretary on a regular basis, meet with the governor on a regular basis, talk about the challenges and most importantly, the potential solutions. We don't just complain, we complain and make recommendations about what can be done. And I think that's what we need to get back to. It's always about bringing people together, agreeing on a plan, understanding the problem. That's how you fix big, hairy, audacious problems.
We have the similar problem in Washington, trying to get Democrats, Republicans work together, get in the same room, try to find common ground and resolve some of the pressing issues that we face. So it's a challenge in the political arena as well. There's been a marked increase in demands for behavioral health services in recent years, whether due to mental health challenges or struggles with addiction. I know that UMass Memorial Health offers a robust array of behavioral health services. Tell us a little more about the system's approach to behavioral health and how you work to keep up with the demands for these services.
Yeah. Well, we don't have enough primary care doctors in this country or in this state, and we definitely don't have enough psychiatrists and psychologists. And so recognizing that, you have to find a way to take the ones that you do have and maximally leverage them, with everything like licensed clinical social workers are working in that space and the support structures around that. And so, what we can't have is a patient that's suffering from depression or substance use disorder that is told you have to wait 3 months before we can get you in and get you seen. So we've created a couple of programs where we can give advice to the doctor currently treating, it might be a primary care doctor, currently treating the patient, and go over the case with them and coach them to how they can take care of the patient. And so for a lot of this in the past, it was, I'm going to send my patient to a psychiatrist. They're going to see him and follow him through, and once a week, for the next 3 months until they're through this depression. We don't have the people to be able to do that. So one of the ways we've been able to kind of innovate and find better ways to do it is get the psychiatrist involved just once, and then let them be a mentor to teaching the primary care doc how to handle that problem. And often this is in pediatrics. We have the same program in place because we're really short on pediatric psychiatrists. So I think once you recognize you don't have enough people to do the care the way you used to, you have to find different ways to do it. And that's where, like, our army of innovators, that's what I call our people that are just looking to solve problems, and we try to give them some funding to try different things. That's what's kind of worked out here, is where you can embed a psychiatrist in a primary care practice or a psychologist. You can get that one-time review. And what happens is the primary care doctor starts to get more comfortable with using some of the typical antidepressants and taking care of patients with similar disorders. And so we have gone to this kind of a system for lots of different diseases. Hepatitis C, we call it an ECHO, where we can get that patient reviewed, make recommendations back to the primary care doc, and then the primary care doc can take it from there and learns and gets better and more comfortable treating the disease over time. So it doesn't solve the primary care doc shortage, but it does help us better leverage this few psychiatrists that we do have.
The New England Council's membership includes health providers of all types and sizes, from elite academic health systems to community hospitals to community health centers. And the one thing that they all have in common is they are all struggling with workforce shortages, whether it's the nurses, the mental health counselors, or all the other important personnel who provide care to the patients. Can you tell us about what your experience has been at UMass Memorial when it comes to workforce shortages and how the system is working to meet those demands?
Well, for us, we think about our caregiver experience as probably job number one here. And our motto is best place to give care, best place to get care, in that order. Because we know if we don't take care of our caregivers, that they aren't going to be able to take care of the patients. And so I often think of it as a compact between management and the frontline workforce, that we're going to meet your legitimate needs. We're going to take care of you the best we can, because we know if we do that, you'll take great care of the patients. And it's worked out extremely well for us. And our vacancy rate now is about where we were pre-COVID, which we're doing much better than others, I think, in that space. The problem is that we're not an isolated business. We work in an ecosystem, that starts with primary care and seeing patients, and secondary care, and then acute hospital care. And most importantly for us, the post-acute care environment, the skilled nursing facilities, the nursing homes, the rehabs, they have not caught back up, and they are still struggling. So you've got hospitals that are running at 110, 115% of capacity, with the skilled nursing facilities that are running at 70% of capacity. So I often say we have all the beds we need in the state. We just don't have the patients, the people at each of the places to be able to move them into the beds. And this is one of those big, hairy problems we have to tackle together, figuring out how we're going to support the post-acute care environment, such that we don't have people sitting in hospital beds, sometimes for months, that should have moved on to the next level of care. And so we're working more closely. I'm a big proponent of vertical integration. I think you want to think about the value stream of healthcare from primary care to the post-acute care environment. And you want to make sure that you have that whole product to offer the patient, not just a piece of it. And so I spend a lot of my time now looking at how we're going to partner with, and potentially even build out or buy, some of the post-acute care environment beds that we need, and try to get them staffed, because they're not able to staff them on their own today.
In any conversation about healthcare these days, two words that come up repeatedly: access, equity. Can you talk about UMass Memorial's health efforts to ensure equitable access to care for the communities that you serve?
Well, we have on the wall in every one of our leadership rooms, including our boardroom, our top 10 metrics. And these are patient-oriented metrics and mostly people-oriented metrics. And I only allow for one financial metric on the wall. And access and equity are always on those. And they are a challenge, but if you can focus on them, you can improve them. For the equity, we every year pick an equity goal. That might be well child visits in children of color. Last year was colorectal cancer screening for people of color. And we have our equity scorecard with probably 50 different metrics that we follow based on race. And every year we pick one of them and say, okay, this is the one we're going to improve this year. And year after year, every time we've picked one, we've been able to focus on it. We've been able to improve on the health equity piece, and have even won what was the inaugural Bernard Tyson Award for health equity, the top award in the country for the work that we've done in that space. And my advice to everyone is, like, if you want to improve something, measure it, put it on the wall, and have it in your face every single day, and know where you're at with that. And that goes for access with us, and that also goes for the equity. On the access piece, if we don't have enough primary care docs, for example, we don't have enough specialists that we need to get all the patients in. So we have to think of, well, how else can we provide the care? And so just now in April, we'll open up our first virtual primary care docs. We'll start to providers will start to see patients and start to bridge care for patients that they're told they have a 6-month wait to get in and see a primary care. Hopefully starting in April, we'll get them in kind of the next week on a virtual appointment such to bridge them. And we just all have to constantly be innovating and looking for new, different ways to do things. It's, we're going to have more patients and less people to take care of them. We better start looking for better ways to take care of patients. And we've done that both on the health equity side and the access side.
Here at the New England Council, our mission is to advocate for federal policies that support economic growth and well-being in our region. So let's take a minute and talk about what's going on in DC these days and how it's impacting you at UMass Memorial Health and the healthcare sector more broadly. You mentioned the hospital at home program as an important tool to ensure access to care. But that program, CMS authorization, I think it expires on January 1st, 25. So how urgent is it that Congress extends the authorization for the program? And then more importantly, what kind of support does this program have among members of Congress?
Well, I couldn't be a more important program for us right now to get an extension on than hospital at home. And coming out of COVID, we took our team that was working on our DCU field hospital, which took care of 1,000 COVID patients, one of the most productive field hospitals in the country that went up. And we took them and we put them right on the hospital at home program. We said, if you can set up a hospital in a convention center, you can set it up in someone's home. And they took what they learned there to create this program under the waiver. And the results have been extraordinary. The patients that are cared for in their home instead of the hospital, they don't get pressure ulcers, they don't fall down in their own homes. They have access to their culturally sensitive food and support structures, and they just do better. And not everybody can be cared for in their home, but those that can do better, and they don't end up coming back to the hospital, and they don't go to a skilled nursing facility, one of the big shortages that we have. It saves the government a lot of money by having somebody cared for in their home, because they don't end up back in the hospital and they don't go to the skilled nursing facilities because they're already home. And so it's probably one of the more frustrating things to say is we all want access. We all want to take the pressure off the emergency departments. We all want to bring the cost of healthcare down. Well, here it is. Right. And yet for political reasons, we just can't get people to understand it. And it's often, I've heard MedPAC, who advises Congress about programs, debated this the other day, and people seem to make up their own facts in 2024 in a way that I don't remember 20 years ago. And it's, here's the data. Like, we can all create our own stories around the data, but let's start with some actual data points. And the challenge right now, I think, in the federal side is people just kind of make up, their own facts, and facts should be facts. And so we're hopeful that program will get renewed. If it doesn't, we'll have 20 patients that are currently on it pushed back to the hospital, put more pressure on the emergency department. The other thing the federal government can do is we need more residency slots in psychiatry, in obstetrics and gynecology, in primary care. And the residency slots are relatively short dollars, overall, to expand. And so as you see OB programs shutting down in rural areas and places with low volume, the shortage of primary care, the shortage of behavioral health, it wouldn't take much of an expense on the part of the government to add some of the residency slots there that are currently frozen. And ultimately, I think better primary care, better behavioral health care is going to lead to lower costs of care for the nation. So, those are a couple of big ones for us that we're going to be pushing.
Patrick Monahan says you're entitled to your opinion, but not to the facts.
Right.
The facts are facts. 1 and 1 is 2. But, I just read a little bit about that hospital at home. I said to myself, how could anybody be opposed to this? Insurance companies will save money. Hospitals can save money. Government can save money. And the patient may get equal and better care at home. What's the problem?
It's not, maybe it almost makes too much sense, right?
I hear. Telehealth is another key tool to expand access to healthcare services, and it seems that leaders on both sides of the aisle have really come to appreciate telehealth as a integral part of modern healthcare. But again, Medicaid authorization must be extended to ensure continued access to these services. How optimistic are you that Congress will take action to extend authorization of telehealth?
Oh, I have to be optimistic, because I'd be too depressed if I thought it wasn't going to be extended. And what I would say the big part of the future of medicine is providing care outside the walls of the hospital. The technology is there, the wearable devices are there. So when we think about our out of hospital continuum, it's virtual primary care, as I talked about, it's telemedicine with existing patients and their consultants. It's remote patient monitoring where a patient can have a wearable on, we can monitor them in the home, we can change their medications based on data we're getting from the home and keep them out of the emergency department, out of the hospital. It's mobile integrated health where we send a paramedic to the home and to see the patient. I sit in my office and I take calls for paramedics where I can see the patient. I've got lab tests, I can give medications, and the patient hasn't left their home. And instead of sitting in the emergency department for 8 hours getting treated, we treat them right in their home. And then the top of the pyramid would be the hospital at home program, where you really take sick people that would otherwise be hospitalized and care for them in their home. And I think, where we have to go over time is more care in the home, less care in the hospital. And that means that we have to get telemedicine waiver renewed, the hospital at home waiver renewed, and really start to use the CMS Innovation Center to look at, instead of changing the payment mechanisms as much, think about how do we allow for care to be done in the home that otherwise had to be done in the clinic or in the hospital. And, and so I'm optimistic that at some point, both Republicans and Democrats will find that common ground you mentioned earlier and say, all right, at some point we have to do what's right for the people of this country. This is what's right for them. Let's keep this going, moving forward.
Congress has taken notice of the workforce shortage in the health care sector, and a variety of proposals aimed at addressing the issue has been introduced. What do you think would be the most effective way for the federal government to help mitigate healthcare workforce shortages? You touched on it a little bit earlier on the residency, but is there something?
I think it takes a long time to grow a doctor, I often say. And so like you could start today trying to open up med schools and nursing schools even, and it'd be a while before you put any sort of a dent. I do think the J-1 visa program should be opened up. I have a lot of anesthesiologists, countries that have a surplus and can generate a surplus of physicians that would love to be over here. And some of my best doctors, we've employed 1,200 doctors, some of the best doctors I have, trained outside of the United States, and bring a diverse way of thinking and a broader way of thinking about some of the problems that we face. And so I think in the short term, I'd love to see the J-1 visa program expanded. I'd love to see the residency slots expanded. That would include bringing even more foreign medical grads into residency slots and to fill some of those needs. And then really, I think what Governor Healy's doing with some of the pre-community college over a certain age for some of the allied health professions like the respiratory therapy, which I trained in, I think that'll help. But we need to make it as easy as possible for people to kind of achieve the American dream here, not to be stuck in the position of a medical assistant. Create those opportunities where, after 5 years, they can move up and become a nurse, become a respiratory therapist, become a physician over time, or a physician's assistant. And education is power. Education is generational wealth, and is what lifts families out of poverty. And I think we're going to have to fix the workforce shortage by a combination of opening up educational opportunities and opening up the borders a little bit through the J-1 visa programs for folks that are ready to work today and trained and able to do the jobs.
But you're doing that right now. The readings that I've done, your apprenticeship program, you've reached out to Quinsigamma Community College and trying to get some of these newly arrived residents here that may not have thought of a healthcare career, that they may have an opportunity now to get a 2-year degree and come right to your hospital. You're doing so much with the newly arrived residents from Ghana and other parts of the world, making them feel welcomed. And so, I mean, kudos to what you're doing. And others should emulate, quite frankly. with that, this concludes our program, Doctor. And I just want to thank you for taking the time to join me. More importantly, thank you and your extraordinary team that you have at UMass Memorial Health for the work that you have done in the past and what you continue to do. You truly are a top-notch healthcare facility, not just here in central Massachusetts, but in New England. You're a gem. And anyone tuning in today, I hope you found it as informative and enlightening as I did. So with that, I thank all of you for tuning in. I hope you truly enjoyed the conversation, and join us next month when our guest will be Tim Barrett, the CEO of the Federal Home Loan Bank of Boston.